A licensed and age-appropriate influenza vaccine is recommended to everyone, aged 6 months and older, annually. This recommendation was particularly important in the flu season of 2020 to 2021, during when the pandemic COVID-19 brought extensive challenges for the healthcare providers. The first contest is to make differentiating diagnoses between seasonal flu and COVID-19 based on symptoms. In times like this, flu vaccination not only reduces the risk of respiratory infections, but also decreases the affliction of co-infections by the two highly contagious viruses. Here are the objectives that I wish to achieve in this lecture. The influenza vaccine brings a simple benefit to the individual. The person gains immunity against influenza virus. Getting vaccinated does not mean that the person will not get infected. Instead, the individual acquires the active immunity artificially through vaccination, and the immunity will help the individual fighting against the infection. That is, influenza vaccine decreases the severity of the symptoms and shortens the duration of the illness. When more and more individuals in the community receive vaccination, the protection against infection of influenza would also cover those who are vulnerable and those who are not immunized. Usually, those who are at higher risk to influenza infection includes the young, the old, and the sick ones. People who are not immunized are at risk to infection. Immunocompromised individuals are at high risk to any types of infection, including influenza. Healthcare personnel are also considered at high risk to contracting flu because of the frequent exposures. Healthcare providers should grab every opportunity to encourage and to administer the influenza vaccination. Per recommendation by Centers for Disease Control and Prevention, as well as the Advisory Committee on Immunization Practices, everyone who is 6 months of age or older should receive licensed and age-appropriate influenza vaccine annually. There are 3 types of influenza vaccines: inactivated, recombinant, and live attenuated influenza vaccines. It is common to see a number tagged at the end of an influenza vaccine. This number indicates that from which influenza viruses, type A and type B, are the antigens incorporated in the preparation. For example, trivalent inactivated influenza vaccine contains antigens from 3 viruses, including 2 type A viruses, H1N1 and H3N2, and 1 lineage of type B virus. Also note that some abbreviations might be used to specify the particular inactivated vaccines. Here we have 4 quadrivalents. This one is an adjuvanted quadrivalent. This one is a cell culture-based quadrivalent. Here we have a high dose and a standard dose quadrivalent inactivated influenza vaccines. Not all vaccine types are appropriate for all clients. There is a minimal age requirement for different types of vaccines. Inactivated influenza vaccine can be given to people 6 months of age and older. The minimal age for recombinant influenza vaccine is 18 years of age. When a live attenuated influenza vaccine can be given to anyone of age 2 or older, it has a long list of contraindications because it contains live viruses. A general contraindication for influenza vaccine is severely allergic reaction to a component contained in the vaccine.
Wait, I am allergic to eggs. I should not take influenza vaccine if I am allergic to eggs.
Great concern. Egg allergy is not a contraindication for influenza vaccine. The ACIP recommends that people who are severely allergic to eggs receive influenza vaccination under medical surveillance.
General precautions for all influenza vaccines include those who are moderately or severely ill, with or without fever, and those who develop Guillain-Barré syndrome within 6 weeks after previous dose of influenza vaccine. A live attenuated influenza vaccine has an extensive list of contraindications. When children or adolescents taking aspirin or salicylate-containing medications during a viral infection, especially flu and chickenpox, there is an increasing risk for developing a fatal disease called Ray's syndrome. Therefore, live virus vaccines are contraindicated in pediatric patients who take aspirin or salicylate-containing therapy. Please teach the parents to avoid using aspirin or salicylate-containing antipyretic for comfort after the children have received a live attenuated virus vaccine. A live attenuated influenza vaccine is also contraindicated in children aged 2 to 4 years with asthma or has experienced symptoms of asthma for the last 12 months. Live viral vaccines are contraindicated for any individuals who are immunocompromised and the close contacts, caregivers of severely immunosuppressed patients. Severely immunosuppressed patients are people who need reverse isolation or protective precaution. Expectant moms are not to take a live viral vaccine of any kind. Active communication between cerebrospinal fluid and the pharynxes, nose, or ear is another contraindication for a live attenuated influenza vaccine. With that said, patients with cochlear implants are not candidates for this vaccine because of the risk for CSF leakage. Antiviral medications can interfere the effectiveness of a live attenuated influenza vaccine. All influenza antivirals should be held for 2 weeks after receiving the live attenuated influenza vaccine. It is contraindicated to take a live attenuated influenza vaccine if the patient has taken oseltamivir or zanamivir within 48 hours before vaccination. For peramivir, a live attenuated influenza vaccine should not be given if the patient has taken this antiviral agent within 5 days before vaccination. Should the patient have taken baloxavir within 17 days before vaccination, an alternative vaccine should be considered.
As we all know, nurses can be assigned to take care of patient who is severely immunosuppressed. What if the nurse took a live attenuated influenza vaccine? Can she or he still take care of a patient who needs reverse isolation?
The answer is yes. The nurse can take care of a severely immunosuppressed patient who is on reverse isolation if this assignment takes place 7 days after the vaccination.
In addition to the general precautions like any other influenza vaccines, the precautions for the live attenuated influenza vaccine include patients who are 5 years of age or older with asthma, and those with underlying medical conditions such as chronic pulmonary, cardiovascular, renal, hepatic, neurologic, hematologic, and metabolic disorders. These conditions can precipitate a severe influenza infection. Here is the table with names, preparations, and dosages for the influenza vaccines available. Let's summarize it. Children under 3 years of age should receive 0.25 milliliter per dose of influenza vaccine. The high-dose quadrivalent vaccines are prepared for seniors aged 65 years and older. The research has indicated that high-dose trivalent provided more efficient protection for this group of population. Anyone else should receive 0.5 milliliter per dose of influenza vaccine. Flu season starts from October through March in the United States. Flu vaccines should not be given too early, way before the season, like in July or August, because the immunity will not last to protect the individual at the late season. Everyone should receive one annual dose of flu vaccine by end of October. However, children of 6 months to 8 years of age who are taking flu vaccine for the first time in life need to take 2 doses of influenza vaccines. The first dose should be given as soon as when the vaccine becomes available, usually in September. Then, after an interval of 4 weeks at least, administer the second dose of vaccine for a full coverage.
What? But my son turns 9 after his ever first influenza vaccine. What should we do?
No problem, because he got his first ever dose when he was 8 years old. He should take the second dose 4 weeks after the first dose.
Oh, no. What if a 0.25 milliliters vaccine was administered by mistake instead of a half a milliliter vaccine?
Well, in a situation like this, we need to see where the patient is when the mistake is found. If the mistake was found immediately, and the patient is still in the clinic, administer another 0.25 milliliters vaccine to make up the full dose. However, if the patient has left the clinic when the mistake was realized, we will need to administer a full dose of half a milliliter vaccine as soon as the patient returns to the clinic.
A live attenuated influenza vaccine is administered as a spray into the nostrils. The intranasal sprayer contains 0.2 milliliter of vaccine. The dose is evenly separated by a divider. When administered this vaccine, have the client sit upright, insert the tip of the sprayer into one nostril, spray the first half of the vaccine into one nostril, remove the attached divider on the sprayer device. Then, repeat the same procedure by spraying the remaining half into the other nostril.
What do I do if the client sneezed, coughed, or if the liquid dripped out after the vaccination? Should I repeat the dose?
Great question. If the client sneezed, coughed, or dripped after vaccination, there is no need to repeat or make up the dose. Although not a contraindication, nasal congestion could affect the effectiveness of vaccine given via intranasal spray. An alternative vaccine and route should be considered.
Inactivated and recombinant influenza vaccines are given via an intramuscular route at a 90-degree angle of needle insertion. Injection site, needle length, and gauge are interrelated and equally important for a safe and efficient vaccination. The injection site should be where with sufficient muscle mass and at the same time away from structures like nerves, blood vessels, and bones. The length of the needle is associated with injection site reaction according to studies. The needle should be long enough to allow injection into the deep muscle mass. A size of 22 to 25 gauge with 1 inch length is preferred. Aspiration when giving IM vaccine is not necessary. It could be painful for infants, though. Here is the table summarizing the anatomical sites recommended for recipients at different ages along with the length of the needle for an intramuscular vaccination. For children at 2 years of age or younger, the preferred site for an IM vaccination is the anterolateral aspect of the thigh. The needle should be 1 inch long to prevent the immunobiologics seeping into the subcutaneous layer. If the second preferred site, which is the gluteal, is used for infants, mind the anatomical landmarks for locating an accurate site. Deltoid can be used for anyone who is 1 year of age or older. As a matter of fact, it is the preferred site for anyone 3 years of age and older. When using deltoid for children, the needle length should be 5/8 to 1 inch long. For adolescents and adults, adjust the length of the needle according to the recipient's body build. Life is dynamic, so is giving a simple vaccine. Both inactivated and recombinant influenza vaccines can be administered with other live or inactivated vaccines as long as these vaccines are given at separate anatomical sites. On the other hand, the live attenuated influenza vaccine can be administered with other live or inactivated vaccines at the same time. If not given at the same time, a minimum interval of 4 weeks is needed to separate two live vaccines. If patients receive an inactivated influenza vaccine, inform the client that minor irritations to the injection site, such as soreness, redness, and swelling, could be experienced. Also, inform the patient that some people might experience symptoms like minor cold, including fever, muscle aches, and headache. Teach the client to rest if feeling tired. Encourage fluid intake as tolerated. Application of a warm compression or taking a hot shower might alleviate the muscle aches or other mild symptoms. Cool compression over the injection site helps alleviating the local discomfort. Instruct the client to report to the physician if experiencing muscle weakness and paralysis. If patient receive a live attenuated influenza vaccine, patient might experience local symptoms such as running nose, nasal congestion, and wheezing. Patient might experience headache, vomiting, muscle aches, fever, sore throat, and cough, symptoms like having a mild flu. Usually, these discomforts are self-limiting and subside in a couple of days. However, if the client experienced severely allergic reaction, call 911. The National Childhood Vaccine Injury Act mandates all healthcare providers to provide a copy of related vaccine information statement to the recipients prior to vaccination. 2 dates should be documented: the editing date of the VIS distributed and the date on which the VIS was provided. Here are the links to the VIS for both live attenuated influenza vaccine and inactivated influenza vaccine. Thank you for taking this lecture.